Okay, I want to thank you guys for being here today. We're going to be talking about reducing blood culture contamination rates in the emergency department. This will be my senior project and my proposal that we bring to the department a new device that will divert the first 2 mils of blood. We will be going over, let's get this back up. So, reducing blood contamination in the blood culture contaminations in the ED. The reason I want to do this is that because over 50% of the blood cultures that are drawn in the emergency department are contaminated. This leads to needless antibiotic therapy. It leads to extended hospital stays, just thousands of dollars that we spend each month on contaminated cultures that actually are false positives. We have, it's about $8,700 per false culture that we have. So our benchmark is to have cultures of the contamination rate below, the national benchmark is 3%. We would like to get ours below 2%. We are currently running at 5.9%. And for those of you who do not know what a blood culture is, it remains to be the gold standard for ruling out infectious diseases, sepsis. Sepsis is our third number 3 killer in the United States for infections. Immediate attention to that. Treatment with antibiotics is necessary, but if we're unnecessarily treating, then we're doing more damage than we are good. We're going to have, why the change is needed again is because we have a 5.9 infection rate in our department. We're trying to reduce that down below the benchmark. We have various people who are drawing our cultures. It may be paramedics, it may be EMTs, the techs that work in our department, nurses, and all may be using a different style of technique to draw that. This is a small chart that we have here. You can see the contamination rates from the first quarter that we ran those, that we're running an average. The highest we got was 6.1. We average again in that 5.9 range, and that's drawing about 650 to 660. This one says monthly, but we're now up to about 1,200 a month cultures that we are drawing. So this is like half of what we were, so you can actually increase this funding times 2 for what we're having. So if we're saying about 300,000 a month, we're up to about 600,000. This is our fishbone chart that you can see what it will do. We'll walk you through the different reasons why. The nurses, the different various people drawing them, EMTs, paramedics, the PRN staff. There are various techniques. Everybody has a different process. Everybody's not using the same skin antiseptic cleaner. We're using different, some's using alcohol, some's using the betadine cleaner, some's using chloroprep, some are not using anything. And they stick, and whatever's on that skin is now going into that bottle. So we have a problem with that. The bottles are not being topped with alcohol before we're cleaning them. Everything's not consistent. We're not doing what we need to be doing. The question is, will changing the skin antiseptic and collection process of blood cultures in the emergency room reduce the contaminated blood culture rates below the national benchmark compared to what it is now? That is our goal. That's the proposal that I'm putting out. There's several different literatures that say that multi-skin antiseptics are tried, and did they work? Maybe there was one that worked, but they were still coming back with high rates of contamination. There was one by Self that stated that the national benchmark was to maintain a contamination rate below 3%, but there's not many that's able to stay with that. This company, Steripath, came out with this new procedure to divert that first 2 mils of blood. So with that new device, we're going to bring in, to make our goal, which it was 5.9, to drop 50% to 2.9%. This is our timeline that we are trying to make sure that we stay on. December, January, through December to our 4th quarter into our 1st quarter of last year, they had high rates. This was the timeline when we're going to try to initiate the plan, how we're going to get it done, how long it's going to take us to get it done, and what will happen in our accountability at the end if it has worked. Our action plan we will initially introduce the new plan to staff via emails and the staff meetings. We will send out invites to in-service training that we will have at the beginning of each shift and at the end of each shift. We will have that device available. The reps from the device company will be there to walk you through how to use it. You can practice using it while you're there. once we get it in, once we go live on our go live date, we will have all the blood cultures will be put into one bag. We'll make blood culture kits. They will be moved to the room where this team is. You will not be able to draw cultures unless you go to that room to get those kits from them. They will escort you to the rooms. They will just be there with you to walk you through the process. It is a different kind of device. I will pass this device around to you guys so you can see it. It does take a little bit of practice working it and using it. It kind of works like a little, it kind of have like a little gun trigger device on it. This is the butterfly needle. We will be using this one, which is a 23 gauge. We will also use the one that connects directly to the IV catheter itself. You will mash this thing. It just presses. You mash, 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 and as you're mashing, the middle chamber will be filling up with blood. It will fill the first 2 milliliters of blood. Then it pushes all the way through, and then you can, on your normal culture, collect your cultures. They have it like that. They want you to do the blood cultures first, and then the tubes. I'll pass that for you guys to look at. To divert, they've had excellent results with that. They've had a rate of like, we'll back up a little bit so you guys can see. They've had several facilities that use the has been using that device. San Antonio military camp, they had a 92% reduction in blood culture contamination rates. That gave them $235,000 in savings. University of Nebraska had a 92% with a $1.8 million in savings, and the VA healthcare in North Texas had a 69% reduction with a savings of $332,000, and that's just over 5 months. So they have the evidence to prove that it's working. The literature proves that it's working. There's no doubt that diverting the first 2 mils of blood should help if there's an infection on the skin. The next problem is going to be if we're not cleaning that skin properly. So in this project, what we're going to do is we're going to focus on one cleaner. That's going to be ChlorPrep. It will be packed into the packages with the new device, with the catheters, with the alcohol, with the blood culture bottles. So everybody will have to go to this room, get these cultures. Everybody will use the same cleaner. They will use the same blood culture bottles, the same collection device, and then they will draw their labs from that. We will reinvestigate it in 6 weeks. The team will be back. The team will be here for 6 weeks, 24 hours a day to assist with drawing. Not really doing the drawing for you. They will just come to you and say, you know, do you need any help? Do you understand how to do it? Are we having any problems with it? How is the device working? We will be checking our contamination rates once a week. We will have feedback to administration to see if this device is like $20 compared to $8,700 of a false positive culture. So the return investment in that would be great if we're using it properly and working. So our goal is to use that, get the kits running, and make sure that we are having So using that kit, we will reinvestigate in 6 weeks what our total for those last 4 weeks of blood culture contaminations have been. Now, putting this in by the 3rd quarter, July 1st to September 30th, total number of cultures drawn was 1,200. We used the new device with an 81% compliance rate, so the total for the quarter infection rate was 0.86. That was our trial run. That's when we used it. This will be the first time that is actually put into be using on a daily basis. It will only be used in the emergency department, and then we will take a look at it again when we get done to see if it is working. So with that, with the literature that proves that using the same antiseptic cleaner, cleaning the skin appropriately, drawing the cultures in a timely manner, and drawing them in the same consistent manner will provide better patient outcomes and better patient satisfaction and better facility satisfaction because we're reducing costs, we're saving thousands and thousands a year, we're reducing days that the patient's staying in the hospital, and we're reducing the needless use of antibiotics. Do you guys have any questions? No. All right. Well, thank you guys for being here. Thank you. Thank you.